Medical administration does not end when the clinic doors lock. For many physicians, the heaviest lifting begins at a desk at home, processing the day's patient files long after the last appointment. Tracking an average primary care workday, data shows nearly 6 distinct hours of a standard shift are spent entirely inside the electronic health record. A JAMA study shows this spills over, adding a mean of 1.77 hours of documentation outside normal office hours. Nearly half of that combined EHR time is dedicated strictly to clerical and administrative tasks, including order entry and billing. These are tasks that pull highly trained specialists away from direct patient contact. With over 20 hours a week devoted to paperwork and administrative tasks, clinical documentation now consumes more than half of a physician's total working life. Updating a patient chart is a rigid, multi-step compliance process. To close a single chart, staff must locate the record, verify that information aligns, check required data fields, route the file to a provider, and follow up on missing elements. When a practice sees 30 or 40 patients a day, that volume compounds quickly. Mid-size practices typically attempt to manage this by rotating documentation tasks among front office staff and medical assistants. Because these employees are already managing phones and scheduling, the documentation becomes a secondary priority, handled by whoever is available. This reliance on overstretched in-house labor is driving up operating costs. According to MGMA data, 9 in 10 practices reported higher costs in 2024 and 2025, with labor as the dominant factor. Delegating documentation to rotating high-turnover staff results in the inconsistent quality and unpredictable turnaround times currently reported by mid-size practices. A national cohort study of over 18,000 ambulatory physicians identified a specific solution for reducing this burden: team-based documentation support. For this model to succeed, the delegation must be high-intensity. The study found that support teams must author at least 40% of the note content to trigger significant reductions in a physician's EHR burden. When practices meet this threshold, they see a significant decrease in after-hours documentation and a simultaneous increase in patient visit volume. Moving to a dedicated documentation role builds institutional knowledge. It eliminates the workflow bottlenecks created when administrative tasks are spread across multiple unspecialized staff members. High-intensity delegation is the evidence-based method for restoring physician capacity and improving practice throughput. Staffingly provides mid-size practices with dedicated virtual medical assistants who execute this high-intensity delegation model. These assistants work natively inside the practice's existing EHR. They handle documentation according to the practice's specific protocols and route completed work directly to the provider for final sign-off. The workflow is managed by a priority engine that automatically ranks incoming tasks by clinical urgency and deadlines. This ensures that the highest value documentation is processed first. Before any document reaches the provider, Staffingly's audit automation runs compliance checks to flag recurring errors. This reduces the risk of audit findings at the point of payer review. By combining human expertise with AI-assisted oversight, the system prevents backlogs while ensuring the integrity of the clinical record. The financial difference is substantial. Hiring an in-house documentation coordinator carries a fully loaded annual cost of approximately $60,800. A dedicated Staffingly VMA runs $21,600 per year. This creates an annual savings of $39,200 per position. For a practice with 3 documentation coordinators, that is over $117,000 returned to the operating margin. This model operates under a strict security framework. Staffingly maintains HIPAA, SOC 2 Type 2, and HITRUS certifications, with all data handled under standard business associate agreements. Go live typically occurs within 48 to 72 hours. Practices can evaluate the impact on their workflow through a 30-day risk-free pilot, with no long-term commitment required. Transitioning quality documentation to a dedicated outsourced model protects a practice's reimbursement integrity while returning clinical hours to its physicians.